Hey everyone, and welcome back to the Firefighters Podcast, where we seek to develop, inspire, and motivate the world of the emergency services operator through a series of wide-ranging conversations. Now, before we go any further, just hit that rate, follow, or subscribe button on whatever platform you're listening to. It's a key performance indicator for us and helps us reach even more people. Now, here's what we've got for you today. My guest on the podcast today is Kristina Stiles. Kristina is an internationally recognized expert and educational resource on burn care, a specialist burns and plastic surgery nurse for over 20 years. She's a keynote speaker, presenter, and content creator across nursing, wound care, trauma, pre-hospital, academic, and industry meetings, including webinars, e-learning modules, app-based resources, and of course, podcasts. She's been the Quality Improvement Project lead, instrumental in developing regional and national clinical practice guidelines on emergency burn care. A referral form for a regional burn care centre to standardise specialist advice given to referring non-specialist clinicians and patient information leaflets on life after burn injury. She's a founder of the British Burns Association Pre-Hospital Special Interest Group, working across speciality boundaries with the fire and rescue services, ambulance services, HEMS, trauma, specialist burn services, tissue viability and wound care, and charity services. She's an innovator with an award-winning project portfolio including Educational Specialist Board Programme, The Burns Game, Children's Book on Burn Prevention and First Aid, The Family Oops and Burns First Aid, and Saving Lives is Not Enough, a report which proposes quality improvement recommendations for pre-hospital burn care to ensure optimal long-term outcomes for burn survivors. Finally, she's also an advocate for the patient voice and recipient of the Outstanding Patient Care and Innovation in Care Awards and a proud ambassador for the National Children's Burns Charity. It is an absolute pleasure to have Kristina on the podcast today and to get a real first-hand account, advice and guidance on how we as first responders can support people on the scenes who experience these horrific injuries in the course of what we do. So without further ado, it's my pleasure to introduce Kristina Stiles. I'll see you on the other side. Shall we go for it?
Let's do it.
So, Chrissy, I was really interested to have you on today because so much of what we experience on the front line, we never really see the aftermath of it, and we're trying to do these early interventions. We're trying to do the best that we think from these experts that have come in and taught us, but also with respect to the instructors that we get, so much of it is legacy stuff, so much of it is archaic, it might not be up to date, the advancements and developments that you see in your sector. What I'd love to do today is to try and sort of get the back door in and segue around all of the, because sometimes they're retired individuals, you know, someone that's done 30 years as a paramedic or whatever, and then they come and teach firefighters how to do their thing. But I want us to try and get into A, some of the latest and greatest, B, some of the experiences you've had from seeing the aftermath of our initial actions and what happens to these people after they leave the fireground. And then also we'll touch on some of the definitions and maybe bust a few myths if you're up for the challenge.
I'm up for it.
Let's go for it. So firstly, obviously people would have heard into the introduction a little bit around your background, but how did you first get into the profession that you're in? And then secondly, build yourself into this niche around burns, trauma and recovery.
So I trained as a nurse in 2003, and one of the elective placements that was being offered was on the burns unit. And actually leading up to that time, I wasn't aware that burns actually existed as a speciality. I just thought people went to hospital and that was it. They were looked after in hospital. But turns out there are very specialist teams looking after these very specialist casualties. And they're quite often placed very remotely away from your local general hospitals. So I asked to go. I asked to go and do an elective placement. I did 3 months as end of training kind of experience. And then as soon as I qualified, I just asked to stay because I loved it so much. So I went in as a staff nurse onto the burns unit, and we rotated through different experiences on the burns unit. You got to experience the theatre setting where patients were operated on the ward where you kind of had walking wounded, intensive care areas where very sick patients were being looked after. And then when patients come back in for their dressing changes or their therapies, so you had an outpatients department as well. So I got to rotate around all of that, and eventually got my additional postgraduate qualifications in burn care and then critical care. And kind of got into teaching. Just the new role came up, and it was network wide, called Burn Care Advisor. And the role was to go outside of the burns unit which was a bit odd. It was unusual to take an educator outside of the burns unit and go where? Well, the idea was that the first people to see and treat our patients are not specialists in burn care. They are often outside in the environments that are inhospitable, that are not conducive to the patient, and therefore we weren't sure what training was delivered previously, but now I know that actually your paramedics, your doctors, your nurses actually get very little in burn speciality specifically as they're doing their training. And yet once we're qualified, we're all expected to know what to do with these patients. So I started working with the fire service, the ambulance service, emergency departments who would treat and then refer patients into our speciality, just to make sure that I could get across to them the key interventions that really, really matter and that can make the outcome better. So that the patient that arrives through our doors many, many hours later is as stable and as well looked after as they possibly can be. So I loved that, because actually what I thought I knew as a specialist nurse sitting in a very lovely warm burns unit with a team of 20 people around me who are there to support the patient and me, always able to ask somebody for advice or help. That's not the situation that you guys operate in. The fire service, the paramedics, even in the emergency department, you know, there's not just this one patient to look after. There are other casualties. There are other people around, and you have to manage the scene. You have to manage the crowd. You have to manage the safety. There's all these other considerations apart from there's a casualty here. Whereas for me, I just have the patient to look after. So I, you know, put on my rose-tinted glasses and went out to speak to the firefighters. And I was learning an awful lot in return, and then was bringing it back to the burn services to say, we have no idea the conditions our patients come from. We have no idea how little resource these teams actually have on scene. But we need to try and work together. So we tell them what's important, and they try to, because you guys are ingenious. I mean, in general, emergency services are incredible because you are proper Blue Peter, top level kind of experts. You will make
police officers, paramedics and firefighters. They're master problem solvers.
Absolutely.
But they are also master generalists. They have we all have a small amount of knowledge, and the needs of the community and the needs of society are growing every single day. So we have to pick up all of the CPD and all of these courses. But like you say, I imagine you and your colleagues were kind of pulling your hair out going, why on earth would they do that? Why has someone done this? Why they've actually hindered the casualty? But it was all best intentions with the limited knowledge and resources that perhaps we had, or you know, the men and women on the front line had at that time, isn't it? This episode of the podcast is brought to you by Gore-Tex Professional Fabrics. Now, we all know the working environment of a firefighter is filled with challenges. We face serious risks on the job, such as heat exhaustion, burns, physical and mental stress, and we frequently come into contact with high levels of toxic chemicals. Now, I have been wearing Gore-Tex for nearly 2 decades on the front line, working in hostile environments, tackling challenging incidents from firefighting to water incidents, and in urban search and rescue environments. Gore-Tex have a well-earned reputation for protecting professionals in the fire and emergency services through their family of highly innovative, waterproof, breathable moisture barriers that exceeds global performance standards and are trusted worldwide. Gore-Tex, going further together.
It is what you don't know, and we're all very quick to judge and become us and them. And I was trying to completely break down those barriers between our services. I mean, it made no sense to me that the service that brings us our sickest patients with the biggest burns, the most significantly injured, we never interact with. Why is that? Why are we not talking to the fire service? Why are you not involved with us? Why are we not sharing what we know? And you guys are not telling us what your capabilities are, and maybe your opportunity to grow and develop, and the casualty element, you know, is developing now, thank goodness. And I think we can improve outcomes for these casualties. And remember, the casualty could be your crewmate. That could be somebody
could
you
be
know.
A child, could be a crewmate, could be somebody in the home, because a lot of these skill sets are transferable, aren't they?
Absolutely.
I wanted us to start with, before we get into our terminology and we get stuck in our own internal bias, because you'll lose me very quickly because I'm only a knuckle dragon firefighter. Let's go with what exactly is a burn, talk to me about the classifications and perhaps the differences between like heat burns, because we're seeing a lot of chemical burns. I know it's not something we discussed actually before we came on today, but if you could take us into that, because we have a lot of these small chemical attacks or individual chemical exposures, ice, as they come through on our tip out sheets. Talk to us about the different classifications of burns and how the body reacts in these states.
So burn is actually a term that's used for many mechanisms of injury. So how we can injure our skin. So there are the thermal elements of injury. So you've got your flame, you've got contact with hot surfaces, and you have scalds, which are hot liquid burns. And then on top of that, like you mentioned, there are chemical injuries, you have electrical injuries, radiation burns, friction burns, and cold burns. So overall, you have 8 different type of mechanisms that can injure a person's skin.
I totally forgot about cold burns. Yeah, we have that on our cylinders and high pressure air when it escapes. Things you don't know is up there. Yeah,
and your CO fire extinguisher, that's why you're told not to hold on to the horn, right? So it happens, and ultimately it's all about skin destruction, tissue destruction, with flame and hot liquids and any contact with anything hot. Ultimately, it's the prolonged exposure. So how long was I in contact with that thing, and that will directly translate to the extent of the damage, the size and the depth of the damage through all of the skin layers. And the really, really deep burns go down to your muscle and down to your bone. It can be really horrendous. So when we're talking about a burn has happened, it could be all of those mechanisms. Probably the most frequently appearing presentation is flame injury in adults. So flame burns tend to be really bad, and in the fire service you will know that you go into those inhospitable environments and you protect yourself because you are aware there's going to be heat, there's going to be flame, there's going to be smoke. So all of those elements to an unprotected casualties would cause damage to their skin. It would cause a really deep damage if you were in that environment for a very long time, and if you breathed in the products of combustion, obviously your airway and your lungs would be also damaged, impairing your exchange of gases like oxygen, and then eventually you'd pass out, lose your consciousness, but you continue breathing all of the products of combustion. So all of the bad gases are still getting into your lungs. And eventually you would die if nobody rescued you, because you become overcome. So it's normally the gases that kill the person before the burn injury kills the person. So flame injuries are bad. They're the biggest, the sickest patients we will look after. So they tend to be big, they tend to be deep, and they tend to have the lung damage on top of that. In children and elderly, we mainly see scald injuries. And that might not be a surprise to you, but hot drink scalds, hot boiling liquid, hot water bottles that burst, that we've filled wrongly with boiling water.
The children pulling the pan off the stove is always the horrible one. I've only ever seen 2 of them in person.
It's typical presentation is that pull down injury. We call it pull down.
Oh, yeah.
So it
when
is
we talk
really,
about
really
scald,
bad.
sorry, is assuming it doesn't go into the mouth, the face, and sort of the esophagus, what's happening to the body when it experiences a burn? Because we throw around these terms like shock and the person's in shock, and I know I'm dragging you right down into the very, very simples, but what I want to do is start at the foundation and then we can build our way from there so we don't lose anybody as we go. What's actually happening to the body as we experience these burns?
So there are a few responses to mention. So the local response, where the burn injury is your kind of skin level response. And there are 3 zones of injury. You have the first kind of very central area where the tissue's degraded, it's damaged beyond repair, we can't change anything. Surrounding that, and remember it's a 3-dimensional zone. If you're just looking at it top down, that's all you see, but stuff is happening underneath through all the other layers. So the second zone is a static zone where the blood flow is static, not a lot is happening, the body is in shock, but actually that's the area that you could reverse the damage in based on your first intervention. So things like first aid and appropriate dressings and pain relief, all of those really matter to that area. We can change the outcome for the patient there. And surrounding that, so the third zone is the inflammation, the bit that really, really hurts, the bit that goes red, the bit that's really annoying and irritating and actually tells us that there is an injury there. So that's local to, you spilled something on your hand and that's what's happening in your tissues. Mm-hmm. It's very different to somebody who has a big burn. So a big burn is 10% surface area of the body in children and above, or 20% surface area in an adult or above. So anything bigger than 10 in a kid, bigger than 20 in an adult would have a systemic inflammatory response. It basically means that your body goes into overdrive because massive area is injured. So all of your inflammatory mediators, everything gets kicked out going, right, we need to fix this. A lot of blood gets diverted away. If there's damage at the skin level, it's not there. So oxygen and nutrients can't get to the tissues. But also what happens as part of the big burn is that all of your tiny little blood vessels also get very leaky. So if you ever see the burn survivor a few hours down the line or even the next day after injury, they're very, very swollen. The body becomes really, really swollen. And it is because of those fluid shifts. Everything that's in your blood vessels, all of that plasma, all of the liquid in your blood vessels starts to leak out. All of that liquid goes into your cells, into your tissue, so you just swell up. So people don't quite recognize that anything that's bigger than 20% surface area burn in an adult will cause that systemic whole body swelling. So if you burnt both of your legs, I would expect your face and your airway to start getting swollen as a result because of that inflammatory response. So it actually can be really tricky to identify, because if you're looking, well, their legs are burnt, why are they struggling for a breath? And that is why. You need to know that this process will happen. The swelling is enormous. People, when they see the impact, they don't almost believe that it's the same person. But that happens, and it lasts for 24-hour window, kind of the first 24 hours when that swelling gets the biggest. And then hopefully we start to mitigate the fluid shifts and start to address that.
This episode is brought to you in partnership with MSA Safety. Today we have them to thank for the improved firefighter safety through connectivity in their brand new connected firefighter system. At the center of the connected firefighter platform is the MSA M1 SCBA with telemetry. That integrates straight in with the Luna system, which is a wireless all-in-one device creating an independent search and rescue network, providing edge detection, enhanced personal thermal imaging, while simplifying post-scene reporting and data retention. All of this then plugs into the FireGrid system for cloud-based connectivity, real-time information, and data-driven decisions for the incident commander. MSA are truly taking massive strides in the future of improved firefighter safety through connectivity in the brand new MSA Connected Firefighter platform. Now back to the show. You alluded to 10 and 20% there.
Yes.
Talk to me about percentage of burns and what's our quick finger in the air rules, because people used to speak about palm of the hand and there was some metrics that were thrown around. Yeah. What's the expected terminology now when we're looking at a percentage of a burn?
The expected terminology is the one that you're most comfortable with. A lot of time is wasted during an incident on scene by medical and non-medical care providers trying to estimate the damn size of the burn. It's too much time wasted. So if you know the palmar surface area, so this method means that it's the patient's palm with fingers. So this is my 1%. So I come with my own little measure. So you don't even have to think, well, what's 1% for her? So 1% and then 1, 2, 3. It's as quick as that. And you can estimate the size of the burn injury by using patient's palm with fingers. That's 1%. So it's probably the quickest. But obviously, if it's your palms against my palms, it's slightly different. So remember, it's the person's, not yours. The other method that's very common in the trauma care and in the emergency services is the rule of nines. The rule of nines is a body map. It's a chart of the body that's divided into areas of 9%. So my arm is 9%. The other arm is 9%. Legs are slightly bigger, so they're 18% for one, but everything is a value of 9. It's really quick and snappy because you can just go, okay, both arms, body, 99999, everything you estimate. But in children, it's hugely inaccurate. There is a specialist ruler that allows you to estimate the size, and that's where the time lag comes in. If you don't know your rule of nines for a kid who's 2 years old, don't even bother. Use another method. Even Palmer, it would be fine. The most accurate method is called Lund and Browder chart. Again, it's a body map that obviously we use in the burn services that tends to be kind of the best standard, most evidenced charting. But pre-hospitally and even in hospital, it is very challenging. It accommodates for changes in body shape. So we start off, say, with a baby whose head is front is 9.5%, back is 9.5%. But for you and me, it would be 3.5% front, 3.5%. So as the chart ages, then no one's going to use that pre-hospitally. It also, front of the thigh, for example, in an adult is 4 3/4. I mean, 3/4. I mean, on a night shift, there's me trying to work out 3/4. I was like, I have no idea what that is. So luckily, there is an app called Mersey Burns app. It was created with our colleagues in the North Burn Network, and it is based on the Lund and Browder chart. It basically allows you a body map on the screen of your device. You draw on the person where the burn injury is, and it tells you what percentage it is. So you don't need to do complex math. So my advice would be, don't worry about the size of the burn estimations. It is a guesstimate. It is just a quick snapshot solution as to, is this a big burn or is it a small burn? Because especially for firefighters, you don't need to estimate whether it's a burn that's 80% or whether it's a burn that's 50%, because what are you going to do with that information? Are you going to deliver any particular treatment because it's 80 or because it's 50? It doesn't matter. What it matters is that it's an adult and their burn is bigger than 20%. So you know instantly this is a severe burn that will require intensive care treatment or high dependency level of care. So this is serious. We take this seriously. Or if it's a child, it's bigger than 10% burn. Right, guys, this is a really big severe burn. We need to take this seriously. So it just gives you a really good indication as to the acuity and severity of that injury. That's all. It doesn't matter if it's 53 or 23. It's big burn.
The next common question is the severity of the burn. So people commonly talk about first, seconds, and third degree burns. Help us understand how we can quickly identify these elements.
So once again, I would say you really don't have to pre-hospitally, because your next step, if you've identified that it's a superficial partial thickness burn or if it's a full thickness burn, what are you going to do with that information?
Yeah. Especially for us, we've got very limited equipment anyway.
Yes. So in the burn service, we need to know, because if it's a superficial burn, it's going to heal by itself, and we could just do dressings and it will heal. If it's a deeper burn, it needs surgery. So they'll need to stay, they'll need to have reconstructive surgery and skin grafting. Pre-hospitally, this information only has value if you have a really deep burn that goes circumferentially around something. So something that goes all the way around. So the burn that's deep, that goes around the trunk, potentially could stop your person who's injured from raising and expanding their chest when they're breathing. So it could actually pose some difficulty to them actually breathing.
Because the skin tightens and everything, doesn't it? Yeah.
If it's around their limb or around their digit, it could occlude blood flow to that area, because it's squeezing. It's inelastic deep burn that's a bit like leathery band that sits around something, and it constricts all of the blood vessels inside. So you want to just notice that, you know what, that's a deep burn. What can we do about it? Well, for chest and neck deep burns, you want to have your medical colleagues nearby who can potentially address that. And actually, it's only the air ambulance, so your HEMS crews, who might be able to address that type of casualty in the very early moments. If it's a limb, we don't expect pre-hospital care practitioners to do anything about that apart from elevate. Raise it up. Because you know yourself, with a sporting injury, you get yourself injured, you get a sprain, it swells up. Burns are like we already discussed, this is what they do. You injure the skin and it starts to swell, but you have a leathery band around the limb and it's swelling inside rather than onto the outside. So all the swelling is going to squeeze your muscles, squeeze your nerves, squeeze your blood vessels. So your skin is dying off, your muscles are dying off. And the way that you buy yourself time, you buy that person some time, is by elevation. You raise it up so that gravity can drain the swelling slowly until they get to the place where that banding can be addressed, usually surgically. So when we're talking about classification of burn depth, we don't talk first, second, third, fourth degree. That is American classification that we don't actually use in the UK.
What's fourth degree?
So we use superficial, which is your sunburn level, kind of redness, ow, it hurts, but nothing's actually happening. Superficial partial thickness, top layer of your skin where the nerve endings are exposed. You've got blistering, but blood supply is really good. So that should heal by itself with dressings. Deep dermal goes through deeper layer of your second layer of your skin, which has got hair follicles, sweat glands, blood vessels, nerve endings. So person is less likely to feel it. The blood vessels are likely to be damaged. So this burn would need help with surgery or full thickness burn. So your last layer down is everything else is burned. Your muscles, your tendons, your bones. So it's a really, really deep burn. Definitely won't heal by itself, definitely needs surgery. So those are the 4 different types of classifications of burn, and everything refers to what are the structures being damaged, how thick is the damage, how far down does it go. So superficial partial thickness, deep dermal, full thickness. None of it matters to you guys pre-hospitally. All you need to know, if it's a big deep burn that goes round something, notice that.
The team here at the podcast are extremely excited to announce our brand new partnership with Patrol Store UK. Patrol Store have been serving the UK's police, fire and emergency communities and first responder sector since 2008, providing leading brands such as Hikes, Magnum, 511, Nebo, Op Zulu, Highlander, AKU and many, many more of our favourites. They are now also supplying bespoke uniform, PPE and station workwear to fire services around the UK. So for all our listeners that are part of your USAR, your HEART team, your ISAR team, your armed response teams, your fire investigation, your NALO, your hazmat and all of the training departments that have got your own budgets, be sure to get the absolute best for your team at a realistic price by contacting Aaron and the team at Patrol Store and referencing the Firefighters podcast. Patrol Store will also be taking part in our listener competition giveaways as well as providing unique discounts to podcast listeners. So for people that are always asking about Hikes boots as an example, that is one unique discount code that is coming to you very soon through Patrol Store. We've also got some incredible bags. I mean, the Op Zulu bags are a game changer. So you know the really Gucci and expensive tactical black bags that everyone's using in CrossFit workouts and taking to the gym and taking to stations? Well, they've basically got that, but it's made better and costs less, because they're not slapping some Gucci expensive brand name on it and it's giving you what you want on a first responder salary. Be sure to keep your eyes in the notes of the episodes for links to unique offers and discount codes. And if you're looking to buy well and buy once, be sure to get in the notes and head over to Patrol Store UK. Now back to the show. I'm torn as to whether or not we go into preferred and best treatments for flame and scald, but I also want to ask more questions around electrical and chemical burns. Will the treatments differ greatly, and which direction should we go in first?
Let's start with the first aid and the initial interventions that everybody would know about. So let's do flame and scald, because that's more common.
So I'll try and give you some of the myths or some of the things that I think, and then, because I always put myself out there as a student, the eternal student that I am. So first and foremost, simplicity, we talk about copious amounts of water. There's been a thing around the fire service around stagnant water in fire trucks. And they say, oh, don't use the water in the fire truck because of Legionnaire's disease and all these things. Our trucks get tested every year for Legionnaire's disease. And I also struggle with the pros and cons of, okay, I've got a little bit of not purely best clean water in the world in this. Am I better off still giving copious amounts via an open-ended branch, or the alternative, which some services enforce, is you use the bottled water off the truck, i.e. the bottled drinking water, but I feel like you're obviously not applying as much water and you very quickly run out of it, and then you're like, oh, well, we've run out of clean water. That's kind of it. So Copious amounts of water. Talk to me about that first. Is there Pete, you're worried about something that's not really relevant there, just lots, or what's your thoughts on that? Because it's also something obviously the general public can take some learnings from.
Yeah. So general public don't know what burns first aid is. There's actually very little knowledge still, despite our efforts of telling them. So anybody who wants to come on the bandwagon with us, and Burn Awareness Day is coming up on 16th of October nationally. So please do join. Burns first aid is 20 minutes of cool running water that's only effective within 3 hours of burn injury. Okay. So 20 minutes of pouring water onto somebody's burn injury that's only effective from the time of burn and 3 hours thereafter. Not 5 minutes past, not 3:30, but literally for the first 3 hours. Obviously, the more immediate application, the better. It's way more effective earlier on than later on. So that information is really important. So for most burns, and we'll talk about chemical a little bit later because that's slightly different, but for most burns, you do your 20 minutes cooling. Now, if you break that down, the confusion often lies with the volume of water that's required. So say you are in a domestic property and you have a shower or you have a tap. That's reasonably easy. It's clean water, is potable water, and you can just shove yourself in the shower and deliver that 20 minutes. But if you're...
Does it matter if it's cold water? Obviously, you don't want it really hot.
So the temperature the temperature of the water really, really matters. So if we're doing lab studies on skin, anything from 2 degrees upwards is effective as first aid. But I am a human being, and unless you're really into ice therapy, it is not something that you do for a burn, because actually the risk of hypothermia is massive. So, and also the skin damage. We talked about frostbite injury, cold burn. You can actually cause that at the tissue level. So the idea is that you cool the burn, but keep the rest of the person warm. So cool the burn, warm the patient is the saying. So the temperature of the water actually, we say, needs to be 15 degrees Celsius or above. And anything up to 25 degrees, even 37 degrees warm is effective, but it's what the person will tolerate. So you need to not get them cold, because hypothermia is single-handedly one of the largest killers in major burns. So we can't get them cold, but we need to cool the burn. So we'll cool the burn with tepid or lukewarm water. But I would say if there's a way to regulate the temperature, you get it as warm as the patient will tolerate. And they will quite often initially find it quite painful, but eventually it's a real comfort and quite a pain-relieving intervention for that person. In fact, when you take away the water cooling, they start hurting.
To the thought, isn't it? To make the water as warm as they will tolerate.
Yes. Yes.
That's surreal. I didn't think about it. Talk to me about the contaminated water, because contaminated is a very lucid term, which is, it's not got radiation in it, but we're talking about the water that comes out of a hydrant is effectively the water that comes out of your tap.
Yes.
So that's my argument for it's okay, but you'll know better than me. Are we doing any damage in this?
Yes. But there is a proviso. So, remember the 3-hour window. You have 3 hours to get them to water. If you are within access of domestic property or even that hospital where the patient is going to, and it's within 3 hours of injury, I would say if you don't have capacity to deliver it on scene straight away, that ticking clock becomes part of your handover to the medical services that are taking the patient away from you. And you say, injury happened half an hour ago. We haven't done first aid. You only have 2.5 hours to do first aid. It becomes that part of handover, and responsibility is theirs to get them to clean water source. The challenge is that paramedics only carry limited amount of bottled water. You already alluded to bottled water. I need 20 minutes worth of it. Their 1 litre bottle of water and 2 bags of saline that they carry is not going to cut it. You'll pour it and within a minute it's gone. So paramedics won't do it. When they get the casualty to A&E department, so you're in the emergency department, and especially if they're very sick, they will not be getting first aid. So you're missing the window of opportunity to intervene, and that will have a consequence. So that's kind of just giving a bit of a background. With regards to
consequence, sorry to interrupt, would the consequence be fatal consequence, or would it just not simply, but the degree of scarring and irreparable damage to the skin?
So this is really good to discuss. Why do we do first aid? I did some teaching yesterday to firefighters, and a lot of them said we've always been told to do cooling, but we never realized why we're doing it. So the why we do cooling is because if you do 20 minutes cooling, it will reduce the size and depth of the burn. So it won't be as bad. It is less likely to need surgery and a skin graft operation. It is less likely to get infected because you don't have the deep necrotic dead tissue in there. You're less likely to stay in hospital for a long period of time, and you're less likely to scar. And that is with the free resource that we all have access to, doing water cooling, that only 30% of all patients get done at the time of their injury. 30% of everybody who gets a burn will have first aid at the time of their injury. The rest don't, with the consequences being the flip side of what I've just said. So that's why we do it. And if you don't do it, yes, you will end up with a deeper, bigger burn that needs surgery that will end up in the scar. And, it's not just a visible thing. It has actual functional complications.
In the absence of copious amounts of clean water, one of the things that a lot of services, I imagine even paramedics, carry in their packed burns gels. I've seen some and heard some, and again, with respect to anybody that makes these things, I'm sure they make lots of other products, so we're not going to badmouth them, but like, people have said, oh, we haven't got copious amounts of water, put the gels on. And we've had some feedback from paramedics around that actually increases contamination. What's our standing on burns gels? Why do we use them? Are they as good or bad? Should we, if we have a burns gel, should we choose that instead of water? Like, what's the pros and cons?
So, flat out, there is no sufficient evidence for the use of hydrogel burn dressings, or the fact that they're in any way as effective as the evidence that we have for water cooling. So water by far is a superior method of cooling a burn. The hydrogel burns dressings come in a pack. They're these jelly-like substances. That's the dressing that you would put on. And it is marketed as a dressing, as analgesic, so pain relief, and as first aid. None of it has been proven with sufficient kind of robust evidence.
They've done well to sell them though, haven't they?
Yeah, I mean, they exist. And I mean, to be fair, then I've been a vehement advocate of water cooling, but obviously if you have nothing, and that's why in airline industry, actually, quite often, if you're in flight and you sustain a burn, they will reach for a hydrogel pack and they will give that to you to put on, because, 20 minutes worth of running water, where you're going to get that from. So if that's all you have and you cannot get somebody to water cooling within 3 hours, then obviously you can use that. Also, it can be used as I'm getting them to water in an hour, but for now I have nothing. So could I put a gel pack on? The trouble is you put it on scene, they get to A&E departments and go, oh, they've got a gel pack on. And then eventually 6 to 12 hours later, they get to the burns unit with that dried on crusty gel pack. And I'm taking it off in the burns unit.
Painful.
Nobody does water cooling once they've seen an intervention's already been applied. So everyone else, after you've applied the gel pack, they will see they've had a gel pack on. We don't need to do first aid. So it almost, like, it misses that essential intervention to reverse the damage in the tissues. So burns communities do not recommend the use of hydrogel burn dressings, simply because if the water is present or access to water can be sourced, and you guys as firefighters can make water happen for us. So a lot of pressure is on you guys to give me clean water. It might not be your appliance water, but you can have a hydrant. You can knock on the door of the next domestic property and ask to use their shower. So please make water happen, because it is single-handedly the one thing that can reduce the depth of the burn by 25%. So the damage that's being done, you've rescued them, they're no longer on fire, but the skin is still being damaged because the heat in the tissues retains and it keeps cooking. You know, it's like if you take the pan off the stove, off the fire, it still stays hot for a period of time. It's the same with the skin. So unless we do water cooling, it's not going to reverse the damage. So water, water, water. Don't make them cold. Cool the burn. Do your 20 minutes or get them to water. That needs to be a priority in care.
Is it an appropriate place to step over now to chemical burns and electrical burns, or shall we continue down the aftercare of flame and scald?
So I'm very aware I haven't actually answered your question about the contaminated water, and I want to address that.
Sorry, yes, please.
So the appliance water, we've done, I mean, I've shared the report, the Saving Lives is Not Enough report with you. One of the elements within that is talking about water strategy. The fire service who's responding to casualties reported, to have a water strategy when you are in attendance. So yes, obviously the best gold standard, fantastic if you have clean potable water that's from a domestic source that we can apply to that casualty. What happens if we don't have that? So if we don't have that, obviously have the 3-hour ticking clock in the back of your head, but could we use the appliance water? So as part of that project, we tested appliance water to see exactly, and it wasn't just Legionella, we're testing for every bug that we know will cause problems in the burn wound. And the reason why we're testing and why we're even concerned about contaminated water is because if you have a burn and you have skin loss, all of a sudden that barrier that normally protects us from our surrounding environment and all the bugs that are already on our skin, all of a sudden all those bugs can migrate in and the patient has massive complications through infections. And obviously, if it's a systemic or a big burn, it could go into sepsis and they could actually die from infective complications. So infection is a massive risk to our patients, and we try to offset that risk as much as we can and protect them, especially when there is skin loss. The appliances that we've tested, yes, they have bugs. They have the typical bugs that live in water, Pseudomonas being one of them. We have, it's a contaminated water that sits for a long period of time without being circulated, used, replenished. Is it bad to use it? So in consultation, and bear in mind, this is expert opinion only. We don't have evidence for it at the moment. So in principle, if you apply unclean water from, say, an appliance tank, it's the last wash that really matters. So the last rinse. The last rinse can be done with the drinkable water that you guys carry for yourselves, for your personal use in bottles. Or potentially you all of a sudden now have got them to a domestic property where you can just shower them down. If unclean water source is used, it's really helpful for us in the burn service to receive a sample of that water. So we can test it for the bugs that have actually gone onto the skin of our patient. And if there's need for antibiotics, we can target those particular bacteria with the antibiotics that we might need to give. But if you use unclean
water... Would the paramedics know, if we provided them with a sample, would that be of use before someone hears this and knee-jerks out and buys 1,000 sample bottles and puts them on every fire engine?
It doesn't need to be...
Would you consider it... Would a paramedic just throw it away, or would they go, bloody doing with this rubbish? Probably, because it's an unfamiliar practice. It is something that we recommend, that we've suggested as part of the Saving Lives is Not Enough report. It doesn't have to. We can always offer it. The worst thing they'll say is no.
Yeah, absolutely. I mean, all you can do is just fill whatever drinkable bottle of water with that and say it's a sample for the burns unit. Can that go with patient? So, and probably the burns unit will go, oh, what the hell is this? But, it's a good start if we start that practice because it gives us insight into what happened to our patient, what was used. And the first thing that we will do once the patient gets as far as the burns unit is to take them to theatre, to operating theatre, where we'll clean their wounds thoroughly and put a definitive dressing on. So they still will get that final clean. It's just ideally if you used, most of our patients, if they're anywhere near a water source themselves, they will run into the sea. They'll jump into the Thames. That they will decide on their own that they're putting themselves out and they're doing first aid. I think it always kind of makes me chuckle a little bit that we're concerned about the appliance water, using appliance water, when your advice to every member of the public, if you're on fire, Pete, what do you say for me to do?
Stop, drop and roll.
Yeah. What am I rolling in? You think that's sterile?
Anything. The filthy woodland that you're in next
not
to the
sterile
bonfire.
Either. Yeah. Not clean. So
doesn't matter if you're rolling dog poo. Just stop, drop and roll.
That's it. Exactly. So you need to have a bit of common sense about it. Can we get the person to clean water? Because we know infection is a massive risk. But if really no is the answer within the 3-hour window, use the appliance water. Give us the sample that we can test it and make sure it's part of the handover. They've had unclean water source.
And make sure that final rinse.
Yeah, the final rinse is the bit that matters.
Okay.
Yeah.
Ever heard the quote that true leaders are readers? Well, we believe this is true. Listeners often ask where we go to keep our finger on the pulse of what's happening in the sector globally. So there are a few key publications which I encourage you to go check out. Now, if you're looking for insights on disaster management, fire protection and firefighting, for us, we go to Asia Pacific Fire Magazine. And when you're looking for the latest on the Middle East fire protection industry and fire services, it's Gulf Fire Magazine. And our quarterly check-in is with International Firefighter Magazine, reporting to municipal, industrial and fire training professionals. Now, next up, and widely accepted to be the global voice for passive and active fire protection. This is a good one. It's International Fire Protection Magazine. And finally, and perhaps the most relevant to our predominantly UK audience, I'd strongly suggest subscribing to UK Fire Magazine, reporting to the United Kingdom fire protection industry and fire services. We're really excited to announce that after a long-standing relationship and mutual respect, we've now partnered with MDM Publishing, who bring you all of these essential publications. Because in a world of change, the learners shall inherit the earth, while the learned shall find themselves perfectly suited for a world that no longer exists. Eric Hoffer said that, and I believe he was right. So keep growing, keep learning, and keep yourself in the know and at the cutting edge of what's happening globally by dropping into the notes. And as a gift from the podcast, you can actually subscribe to any of these publications for free using the link in our notes. Now back to the show. Talk to me about cling film. So I just thought about this when you were talking then, because I remember seeing it still sits in a lot of our first aid packs because, okay, Chrissy, I've done my 20 minutes, tick of the box, final rinse. Now I'm going to wrap them in cling film because that's what we do. I think we're doing that again from a contamination perspective. If we've got all these tools in the toolbox, so I've got my hydrogel pack and I've got my cling film, but I've sourced some clean water, so I've done my 20 minutes, final rinse was clean. What am I going to do with them then? Should I be putting cling film on it? Should we still carry it? Is that just an old wives' tale?
No, it's actually a guidance from the British Burn Association. You have to put on cling film. So cling film is not a dressing. It is a wound cover. And it, again, covers all those exposed wound areas from the ambient environment. If you ever had a blister or a cut, as soon as you expose it to air, it stings like hell. So the idea is once you've done your water cooling, you need to protect the wound and keep hydrogels to one side, put on cling film. There is a technique to applying cling film. I mean, it just slides off a very wet, slidey person, especially when there's skin loss. It doesn't stay put. But the idea is not for it to stay put, it's just to be there whilst they're being transferred to the hospital that they can put on proper dressings. So at the scene, do the cooling, apply cling film in layers. So you're just literally laying it onto the person, on their chest, on their limbs. No circumferential wrapping. Because if you wrap around, and we all love to wrap, we take the roll and literally just start wrapping their torso around. Like, that's it, I'm going to dress you up in this thing. The trouble is that cling film is not elastic. So it won't stretch. So if you wrapped it around my chest and I'm now trying to breathe, it becomes very, very difficult. Or if you wrapped it around my limb and it's swelling up because of the burn injury, that could be quite a complicated thing because you're compromising my blood supply. So sheets of cling film. So for a limb, top layer laid on underneath, and you literally scrunch it away from the limb. It just needs to lay on whilst they're being taken to the hospital. But it is probably the best thing. Do not put it on their face. I have to say this because it keeps being applied. We don't dress faces. You leave the face open to air. And if you have some gauze in your IEC packs and your responder packs, then wet the gauze and you can then lay it on their face. So, and in fact, once you've done your first aid, the hydrogels for the face is what a lot of the air ambulances have still retained, and they use it for faces.
People will remember the famous pictures from the London bombings with, I think there's a lady specifically had one on her face, wasn't there?
That's it, yeah. So for comfort, after you've done your cooling, you can use anything like that. But for transfer, so the worry with hydrogels on big surface areas that it can cause hypothermia because you're keeping them wet and wet for a prolonged period of time. So ideally cling film to the body, but if you need to use hydrogels on the face, that can be used, or leave it open until they get to the hospital and have proper dressings applied. So that's cling film. Cling film is brilliant because it not only shields the nerve endings from feeling pain, it also allows you that continuous assessment. So in a lot of A&E departments, we will train them to say, actually, you can put cling film on whilst they're with you as well, because if you need to keep assessing, is that burn wound still okay? Is it still progressing? You don't need to take off a dressing in order to see, which causes pain. It's something you can see through. It doesn't allow any more bugs to get through. It's not sterile. We know it's not sterile. It doesn't need to be sterile. It just needs to be a barrier. It just needs to be something that's a protecting surface whilst the patient is being transferred from one place to the next place. And then once they get to us, they go to theatre, we clean them, and we put on proper dressings.
Love it. Electrical and chemical.
Yes.
We're seeing a lot more chemical burns these days, a lot of chemical attacks, people throwing things in people's faces, and also people ingesting things, swallowing something, and we're not quite sure what to do with it when they do that. Which rabbit hole do you want to explore first?
So I won't talk about ingested stuff because that becomes the domain of the general surgeons. So because it's internal damage, it's not, we're a skin specialist in burn care, so we can manage the outside, but once the inside's involved, there's no dressing, there's no surgery, so we kind of step away. Chemical injuries to skin, faces, ocular surfaces, they can be absolutely devastating. Depending on the amount of chemical, depending on the concentration of the chemical and the time of contact, so how long were you in contact with this chemical, all of that, again, will lead to how severe, how bad this is. And all the time the chemical is on the skin, the damage is being done. Now, there are two types of chemicals. There's like the whole band of pH scale. You have the acids, which are the low end of the pH scale that cause damage by coagulative necrosis, which basically means that they create a hard crust in your proteins. So they crust you up, very quick, deep damage, and that's the damage done. Or you have your other end of the pH scale, which is the high end of the pH scale, and that's your alkalis. And they cause liquefative necrosis. They liquefy your skin. So they make it liquid and mushy. Alkalis are much, much worse from the point of view that they continue burrowing through your skin, through all the layers until we washed it off. So that's why the response to anybody with a chemical injury is irrigation. You start it as quickly as you possibly can. You need to brush off any dry chemicals that might be still on them. If their clothing is contaminated, that needs to be removed. But again, don't let them do this. If my body is affected and it's soaking wet with chemical, you take it over your face, now your face is affected. So it needs to be carefully done. And normally the advice is that if you are the responder on scene, you talk the casualty through how to manage it as much as possible. If they're capable of doing it, how to do it themselves. So you don't have to be at arm's length from them, because the first point of call with any scene is safety, your safety as a responder. You're approaching somebody who's had a chemical spill on them. As soon as you touch them, as soon as you start irrigation, that chemical could splash back on you and then you're affected. So protect yourself first. Talk them through as much as possible of how to remove. You can cut their clothing from their back so they can literally take it off forward like a gown. So it means that none of this over the head business needs to happen. And then you talk them through irrigation. If that can't happen and you have to get close to them, please, please, please protect your hands, protect your eyes, protect your faces. So visor down, double glove, and then start irrigation, because that splashback is deadly. So you want to be completely covered up so none of your skin is exposed as you're doing it. The irrigation...
I've never heard that advice of cutting it from the back.
Yeah.
That's a really good piece of advice.
Top tip from Chrissy.
It like a gown. No, it is, because a jacket is actually quite difficult to take off, isn't it?
Yeah.
If you were to cut down the front, you're still a lot of faffing about and moving and potential for things to flick off and in your direct. Like you say, you just cut from the back.
If somebody is injured, like you say, it tends to be assault on the face. They throw stuff into their face. So they tend to bend over forward. So if you're working at their front, you're actually getting them to can you just stand up? And then if you're working from the back, they're already in that position. So you're just cutting and then they can take it off. So, cut from the back.
So irrigation.
Yes. Irrigation.
Copious amounts of water. 20 minutes, is there a timing on this?
So, copious level of irrigation with water is what's advised. We cannot say past 15 minutes that it's any more effective. But because of obviously in thermal injuries, we'll say 20 minutes water. We've rounded it up to 20 for chemical, just so that nobody starts getting confused. Is it 15? Is it 20? Yeah. So we've said 20. In reality, actually, the patient tends to be still in pain, and irrigation takes much, much longer. It can take many, many hours, sometimes even the few days after, when their pH is still not normalized. So, all the time they're with you, I would say you irrigate if they're not getting cold. Again, hypothermia is a massive issue. So there are two problems with, you continuously keeping them warm and putting loads and loads of water on this person, because they're going to start getting cold, especially if they're stood in the middle of the pavement where you're trying to do this irrigation. It's not ideal. But the other thing is that the runoff will be a slightly diluted same chemical. So where is your water going? I'm not even thinking about environmental consideration of the public health, but also where on their skin is it going? Because if my face is affected with the chemical and you're washing me down from the top down, it's now running down the rest of my body, where now you've moved something that was 3% to the rest of my body. So how big is this burn now? So we need to be very mindful of where that liquid is running. You have to treat the runoff as active chemical. So if it's on one side of my face, don't allow it to run towards the other. So you need to position the person, or advise them to position themselves, if possible, how to make it run off away from the uninjured parts of their body. Can we wrap them up so they're protected and then you just irrigate in the bit that's injured? It is not simple. It's that, troubleshooting on scene, problem solving on the fly that you guys are so good at. But that's the bit to concern yourselves with. Lots of water, continue irrigation. Yes, 20 minutes is what's needed, but actually it will take much longer than that for them to be pain free, or for you to irrigate the chemical. And once they're in the back of an ambulance, that needs to continue. And we talked about cling film after you've done the irrigation. With chemical injuries, we do not apply cling film after, because you cannot guarantee you've removed the chemical from the tissues. So if you wrap it in cling film and the chemical's still there, you're just making it cook, inside of that environment. So irrigation continues all the way to emergency department.
So irrigation, quickest route away from the person so as not to spread it onto them. Re-road packs, tough cut scissors, cutting away from the back. Stop if they are showing signs of hypothermia or they're becoming very, very cold. Continue irrigation for as long as they can tolerate it, and as long as they're not getting cold.
There is a solution. There's a washing solution called diphoterin, which a lot of the burn services nationally have. It comes as an aerosol spray. It comes as a liquid and looks like a saline bag. It also comes in a bottle with an eyelet that you can actually open the eyes. So this solution is called amphoteric chelating solution, and it's something that would reverse the damage of either acid or alkali burn within a minute. So it reverses the damage. As soon as you apply it, it very quickly normalizes the pH. And the reason why it's chelating is it's like it has these crab-like molecules that basically grab the chemical and pull it out of the tissues. So it grabs the chemical and takes it out. So you don't have to worry about the runoff. You don't have to worry about copious irrigation. You just apply it, and then that's your first aid. Obviously, by the time they get as far as the burns unit, it is quite late and many, many hours later, and the damage of that chemical, is ongoing. So the British Burn Association first aid guidelines for chemical injuries, we advocate all 3 levels. You can use water for irrigation. If that's all you have, use that. If you don't have water, you could use saline, any other liquid that's on the ambulance service truck. Or if you have this amphoteric solution, diphoterin, then you use that. So a lot of the emergency services are, we're in discussions with trying to see if it's, feasible for you guys to carry it. Sometimes it's sold on the premise that actually we need to protect ourselves first. So if you as a crew member get injured with a chemical, then actually that's a really good thing to carry on your belt, that you could potentially, neutralize the chemical and sort that out. But obviously
we'd certainly expect it on HEMS or Heart Team or something like that. Some of the specialist units is probably nice to see on.
It would be great. Yeah, absolutely. But just to be aware that this actually exists, and a lot of industrial
I was going to say industrial premises as part of their risk assessments. They'll all have their quick showers and their chemical suits and stuff like that. But because it's a highly anticipated risk in those environments, isn't it?
Yes, absolutely. So that they have it. And that's actually a really good point for first responders. So emergency services arriving on scene of an industrial accident. If there is already first aid ongoing and you see this kind of these orange blue bottles, being utilized, you say this diphoterin, what is this? We have water. The diphoterin actually could be the better solution rather than loads and loads of water. So don't remove that and start splashing water on them, because that stuff will work. So, if they've got it, let them use it, because that's part of their first aid. If they don't have anything and all you have is water, that's perfect. Like, just start irrigation as soon as you can. One of the things that I didn't mention is the eyes as a priority. So the things that are really important to, like, quality of life outcome for the person. If the face is splashed and the chemical is in the eyes, they could very quickly lose their eyesight as a long-term consequence. So the areas that are important to us as humans will be, obviously nobody wants to be disfigured from the burn, but equally...
Who's that young lady's name? She's a great speaker, isn't she?
Katie Piper.
Katie, she's had copious surgeries. A boyfriend attack with a chemical exposure.
He arranged for someone else to splash, chemical onto her, and she has got partial sight in one eye.
She's had lots of surgeries on her left eye specifically, hasn't she?
Exactly.
Or something like that.
And that's the consequence. So, unfortunately with our skin, with our skin, we have a bit more protection because there's many, many layers. And by the time the chemical works its way through, it takes a little bit of time. But with eyes, that's your epithelial layer there, that it goes straight in and it's very quickly damaged. So we need to be more aware of, if you are attending somebody and they're closing their eyes shut and the chemical's on their face, the reason they're closing their eyes is because it hurts to open, the chemical is in there. So the priorities need to be, if we are going to irrigate anything for them, it's the eyes. How can we prioritize the eyes? And be prepared that if somebody's got skin damage to their face, you're gloved up. It's just going to keep sliding on their skin. It's near on impossible to work with. So you need to have gauze or something where you can get purchase on the skin to open the eyelids. And then that's it. That's you stuck. You're there, opening their eyes up at top and bottom. And then you need another crewmate who's going to start irrigation of their eyes. So, and it's one of those things that, because quite often the reaction is to shut eyes, we irrigate what we can and don't go for the difficult bit. But actually, that's the bit that's so important.
Such a fear, isn't it? Losing your eyesight.
Yeah, absolutely.
That would just suck so much. There was a gentleman I was listening to recently. I won't go down a rabbit hole, but he got glassed. Some sort of celebrity got glassed at Christmas, and someone just shoved it into his face, and he's blind.
Yeah.
And it's just, that's it.
Yeah.
But then and again, no one wishes for it. Many people live a fulfilling life that have never had their eyesight. But to lose it, to have it and lose it, would be, like you say, one of the biggest negative life outcomes, really, for people. Such a thing to be robbed of.
And we're talking about the casualty that you attend, but equally you as a responder. If you've not protected your own, you've not covered your face, you've not worn your protective glasses or whatever kit that's provided for you for those incidents, that could be you. Or that could be your mate. So it is a horrendous life-changing injury that will affect you for the rest of your life. So just be prepared that chemicals are vicious. You don't know what you're dealing with. They could have had water splashed in their face, but it doesn't matter. If it's been reported, something's happened to them, let's just protect yourself before you go anywhere near them.
Big lesson learned for me. Early in my career, I went to an incident where a young man had cut his wrists and jumped off a bridge, tried to jump in front of a train that stopped. We went to it and they were trying to get him off the tracks, and he's really angry and upset that he wasn't successful. And he spat in my face and the face of my colleague. 3 months worth of visits to the hospital to see if I've got hepatitis and everything like that. Luckily, I didn't have anything, but it was one of those where I was like, such a little thing, because we associate our visors with road traffic collisions. Oh, I don't want the glass getting in my eyes. I don't want a bit of shard of metal. But all of those bodily fluids can have a significant damage of a lifetime. Not just, oh, I've got a cut on my face. Not saying that that's not a big thing, but like, you know what I mean? Like, I'm never going to do that again. Ever, ever, ever. It seems silly because it almost seems impersonal when you're talking to a casualty that I've got my visor down, but you've got to do it.
You have. It's certainly with chemical injuries, you don't want to mess around. Things that are important to us, for quality of life, you want to be able to see, you don't want to be disfigured on your face, and you want to be able to use your hands. So certainly from prioritizing areas that you do irrigation for, or say you have a major burn casualty that you've just rescued from a house fire and you think, okay, if I cool all of them, they're going to get really hypothermic. Where do I start? Well, you start in the bits that are going to be important for them in the long term. It's going to be their face, it's going to be their hands, it's going to be their genitals, and it's going to be their feet. So you can wrap them up nice and warm, but actually if you can cool anything for them on scene, prioritize the bits that would be important to you. If you were burnt there, would you want first aid? Would you want that damage to be reversed as much as possible? Well, yes.
Yeah. Again, you say genitals and feet. Such an obvious one when you think about it.
Yeah.
Very personal and fulfilling area. You can't walk, life's going to suck forever.
Yeah.
You can't engage in an intimate relationship. Tremendously detrimental to your happiness and to sort of your future in general.
It's difficult to think of that, I think, like when you're attending, there's so much for you guys to contend with on scene.
Because also we're so like, oh God, I don't want to cut Chrissy's pants off because then someone's going to think I'm a pervert or a whatever. But you're like, yeah, okay, get the re-road packs, get a blanket, whatever. We've got to irrigate this. I'd rather check, and everything's on CCTV anyway. The trucks have got CCTV. I'd rather check, let's get it off, let's irrigate. She seems to have a splash of something. She's in so much pain, I can't really tell where it is or where it isn't. Let's get it all off. We've got things we can put on her to protect her dignity.
And
because
remember,
I never want
if they're
someone
lying
going,
down,
I wish the firefighters had done X.
Exactly.
Yeah.
And we've had those incidents. I'd tell stories of exactly incidents like that where firefighters turned up and prioritised the building on fire rather than the casualty that's laying on the green salvage sheet. And paramedics are nowhere near for, 20 minutes, half an hour, especially in those more urban areas where, the very, the access can be quicker, but then you've got the remote, settings where you could be waiting for a very long time, and if no one's attending to that casualty, that person, it's a human being, we have capacity to intervene from the very early moments. And whatever you can do, you should do. So cutting off clothes, doing the cooling, and that's an important point. If you're doing the cooling, you have to take the clothing off first. Otherwise, what you're trying to cool, the clothes, anything that's loose and is coming off, you have to remove and then do the cooling. The other thing with hypothermia is that actually you could do segmental cooling. You do a bit at a time. You don't need to cool the whole person all at once. You can do 20 minutes on the legs. The rest of them are staying nice and warm and wrapped
still
up.
Going to be effective.
Then, just do parts. It's fine. Just make it part of the handover.
If you're a regular listener to the podcast, then chances are you are big into your own personal development and the development of firefighters around you. So I wanted to remind you of our mobile app Drillbook. This is a free training and development resources made by firefighters for firefighters. Heading on to Drillbook, you will find incident debriefs, radio messages, notes and lines, quick reference guides, quizzes every single day. We've got useful links to the ERG, to Web Rescue, to Jessup, Euro Rescue, 10-second triage, National Operational Guidance, and not to mention our daily quizzes where you will find questions on extrication, casualty handling, breathing apparatus, fire development, water rescue, rope rescue, you name it. It is the go-to resource if you've got a spare 5 minutes on the firehouse to develop yourself and those around you. Not only that, if you're looking to get into the fire service, we've got advice on there on interview questions, interview answers. You can build your own questioning in there. And again, remember, this is built by firefighters for firefighters, so you can add your own drills in there. You can pick the drills that you find the most favorite. There is literally hundreds of training ideas, hundreds of drills in there. Remember, this app is absolutely free and it grows every single day down to the contributions of our thousands and thousands of users. It's freely available on Android, Apple, and you will find it in the links for this podcast. Remember, it's called personal development. The clue's in the name. You've got to work twice as hard on yourself as you do on the job. So always be growing, always be developing. Now let's get back to the show. Electrical burns. I don't want us to forget them because I always think these are very, very funny ones. How they present, sometimes it doesn't look like a damage, but it is a. And again, as a first responder, there's probably actually very, very little we can do. But if you could just take us through that quickly.
So electrical injuries are split into two, depending on the voltage that's been involved. So in domestic properties, you're quite likely to sustain a low voltage injury. Also, because of the AC conduction within the plug sockets. I'm not an expert, so don't quote me necessarily. But the way that electricity flows, my understanding, in our domestic properties, it's an on-off kind of electricity. So if you are if you touch something, it allows you to let
current,
go.
Not a direct current, yeah.
That's it.
And it will trip with the residual current device. It will trip anyway.
Less likely to sustain a significant injury. So the concerns with domestic property electrical injury, are they still awake and talking, or are they in cardiac arrest? Quite often they'll still be awake and talking. If the paramedics are there, we're asked to check the tracing of the heart, so can they do an ECG? But the initial thing, you're awake, you're talking, and you're showing me the finger that hurts. Okay, right. So it's domestic property, low voltage injury. What I see there, is there any other wounds, anything else that hurts on you anywhere else? Is there an exit wound? It's not always. Sometimes it is just one. So you see what you get, and that's normally reasonably deep. So the electrical injuries tend to be deep. The worry is, has it traveled anywhere else? But in domestic property, maybe not so much. It might be really close. There might be an entry and exit point actually quite close by. It might be really, really far away. So you're looking for two wounds, or just generally assessing where they are. But the main concern is not just the burn, but actually, is their heart still okay? And if they're up and about and they've not lost consciousness, then hopefully they're okay. You hand them over to paramedics to be checked over. If their heart tracing is okay, they actually are okay to proceed to the burn service to have their burn wound looked at. Very different story with high voltage injury, that direct current. So that anything over 1,000 volts is considered a high voltage, although I wouldn't want 900 volts either, to be fair. But basically your high voltage, your third rail, your overhead power lines, those are quite significant injuries, right?
Third rail is a very good point, actually. Yeah. So third rail, and also agricultural settings, farms where they've got 3-phase and things like this. And obviously industry, where we're experiencing a lot of voltage.
So high voltage electricity can kill you, ultimately. So it's a massive current. If you're in contact with that, it freezes you on the spot attached to that direct current, and it's not switching off. So it causes internal and external damage, and it depends again on the duration of the contact. And quite often in high voltage injuries, there's very high mortality rates. So the people tend to die. So if you guys are attending, the casualty is quite likely to be in cardiac arrest. So the priority is not the burn. The priority is your safety. You need to switch stuff off that's hurt them, and before you can approach. But then once you get to them, it's cardiac arrest. That's what it is. That's what you're dealing with, not the burn.
And nothing we're going to do in our standard CPR defibrillator routine
no different.
is going to make things worse.
No, absolutely not. Okay. They're dead. They're dead, and you need to deal with the dead person. That you try to restart their heart, you try to shock them back into being alive, and then you can cart them off to the hospital to deal with. But the concern is that even if you do get them back, or if they say they somehow are still awake and talking after that, the injury that you see is like a tip of an iceberg. So you could have somebody who touched an electrical cable and it went off somewhere else. So I was visiting a burns unit abroad, actually, and there was a young lad in their intensive care unit who was just started as a mechanic in a garage, and he was opening up shop. Went to switch the lights on, and that was live. Somehow he got electrocuted really badly. So his burn was on his hand, and then it came out in his neck. So entry and exit. An exit is always more dramatic, more explosive. So it gives the entry and exit wounds, the two wounds give you
He was alive?
Alive.
Wow.
Alive, yes. I mean, life-changing injury, no voice box anymore, completely blew out all of that, and alive. The care.
It's almost worse if you find them alive. Yeah. Like I've been to people with horrific burns, and not like you don't want them to be dead, but you're like, oh my God, I've got to do something with them now.
Yeah,
they're still alive. Jesus Christ.
And I think I think that's actually quite an important point. I know you've done quite a few podcasts on mental health and your own well-being as a responder. So we are prepared, like we receive training ultimately as professionals. We do get training in mental health, and there is support available through our organizations.
And you're expecting to see the worst case. If they're arriving to you in a specialist burns unit, you're not surprised that this person has got severe, but that's why they've come to you.
But your visible reaction to seeing the casualty, especially when they're awake, matters to them. Yeah. They're looking at you to go, how bad is this? How bad am I? And we see it quite often in intensive care units when the family members walk in for the first time to see the person. It is the family's response or the person entering that upsets the person, because all of a sudden they realize, what's wrong with me? Give me a mirror. How bad is it? What is it? Until the point that you respond to them, they have no idea actually how bad it is. So our job as professionals attending is to not give anything away. You're there in a supportive mode. You're there, right? I know you're in pain. Whatever it is, like, we've got you. We were here. We're going to help. So just a little note on that. Like, don't let it give away. Don't go, oh shit, how bad. Like, have you seen this? I'm sure nobody does that. But sometimes our own it's almost subconscious that we give ourselves away. So prepare, you're going in, person's reported, there's going to be somebody badly injured. Can we just, poker face it a little bit for the time being? Then we can debrief. But initially, when you're with that casualty, with that awake person looking for information from all of you around them, it's important that we don't give it away. We don't make them any more upset. Already horrible thing has happened to them. So let's just deal with that. So entry exit point in an electrical injury, it gives you really good information where the electricity is gone. Quite often you'll see not a big area on one part and not a big area on the other part. And you're like, not a bad burn. Like, okay, it's deep here and deep there, but that's not bad. But actually the damage is internal. Electricity naturally travels through tissues in our body that generally conduct electricity, and that's muscle and that's nerve. So all of those fibers internally where electricity just gone, oh whoosh, this is really good highway for me. All of that tissue is also damaged and quite often really, really badly burnt. You just can't visualize it. So the concern then becomes that any damaged tissue inside, it starts to swell. So you're in that concern. I was telling you about the circumferential burns. Same thing happens, but from inside out. You've got damaged tissue on the inside and it starts to swell up, and it can only go so far, and it occludes all of the blood vessels inside. and then they can lose their fingers, they can lose their limbs through amputation that we have to do because everything's dead on the inside. So just being very mindful that you might not be able to see how bad it is, but it's bad. It's really bad on the inside. We had a gentleman who was on a golf course and got hit by lightning as he was teeing off. So he had a burn in his hands where he was holding the club, and in his feet where the metal studs are, where it went through him. So you think, well, where is the burn? It's gone from his hand all the way through his body. And the main organ we really worry about is the heart, because it's the biggest muscle. It's the big muscle that's really, really important for keeping us alive. And that's why the cardiac kind of response is really important. Are they awake? Are they dead and cardiac arrest? And we need to do something about that heart. So you keep them alive. And if that's the priority, we need to do CPR and defib. But if they're awake, you then give yourselves a bit of an idea. It's gone in there. It's exited there. This is going to be really bad. They need to go.
Should we do any treatment to the entry or exit wound?
So there's still going to be heat involved. So the bits that you can see, you can still cool. And that will be really helpful. So yes, absolutely. Do first aid. Cover them with cling film and then they go. Your main consideration will be if they're not in the cardiac arrest yet, their heart potentially has been affected by electricity, so they could. So you need to anticipate that actually this is
get the
very
defib
unstable.
on them anyway and just let it read.
Absolutely. Yeah. You need to you move them gently, you kind of recover them really, really gently, because anything can upset the heart. So just being very aware that, that needs to be checked thoroughly, that needs to be in the hospital environment, that person needs a support beyond what we're able to give. But should they all of a sudden go into cardiac arrest, we have all the equipment here already because we knew it was an electrical mechanism that has the potential to send them into cardiac arrest.
I want to move, because the eternal student beyond me wants to move beyond the fireground a little bit now, because I'm interested, and perhaps we could start with electrical burns as we're there already, but I do want to ask you about skin grafts as well. So there's lots we can't do, and these are outside of our sphere of influence, but there is conversations around the watch tables and stuff like this. What happens to this person when they go beyond that? So if we start perhaps as we're there with an electrical burn, like what are you going to do? Not you specifically. What's the team going to do about all of that internal burning? And then talk to me about the limitations, because people say, skin graft, and they use it as a throwaway term like it's going to solve everything and fix everything. Are there limitations to this, and sort of some of the aftercare? I know, try and give it to me in 7-year-old language so that we don't lose me and perhaps the people that are listening as well, but talk to me about that aftercare process and things that you and the team will do.
So when the person arrives to the burn service, regardless of the mechanism of the burn, to be fair, like I said, we will need to do an assessment of them. So there is the general trauma approach where you assess whether, their airway, breathing, circulation stable, have they got any other injuries, and then finally you look at the burn injury. How big, how deep does this need surgery? So they may be suitable for surgery pretty much straight away. So if they've come in the night, they might have the surgery the next day. Or if they're...
Is that plastic surgery? And I know that's a common catch-all term. Or is it still like surviving surgery or a cosmetic? Or do we do it all in the same time? I don't know.
No. So the initial surgery is to debride. So that's to remove the dead and damaged tissue. You're removing the bit that's making your patient sick. The bit that's dead is going to continue creating really bad stuff. It is sending lots of bad stuff across the body, making my patients sicker. We need to cut it away to make them better. But if you're cutting that bad stuff away down to live, healthy tissue, it's going to be alive, so it's bleeding. So you need to manage the bleeding, and also you need to then cover it with something, because you've now created this big open wound, which is where the skin grafting comes in. So burn surgeons are
Sorry, how do you do that one with an electrical burn?
Yeah.
Do you cut open and follow the track? Or
so with electrical...
Very complex question. Feel free to stop me at any point if we think we're going too far.
So with any deep burn that goes inside kind of is internal. There's consideration for internal. So with electrical burn injuries, if you're concerned that there is internal damage, say in the limb, you would cut into the tissues to perform a fasciotomy. So you cut past the skin, you cut past the fat, you visualize the muscle that's in there. And if it's anything other than bright red and vibrant pink, quite often it's grey or black.
God.
You need to cut it open to see if there is any muscle that's still alive. So you need to open up to create, to release the pressure within the muscle, within the swollen tissue. But equally, you might be assessing what is alive and what isn't. And anything that isn't alive would need to be surgically removed. You know, surgeons would do that.
That's got to be very invasive.
It is very invasive. It creates a massive defect. So if people survive those injuries, you know, ultimately you take away a large chunk of the muscle out of your body, it's visible. You can see that there's a defect in your body, but you're alive. So ultimately this becomes about limb saving and about life saving. So these are the two parameters. Ultimately, we want to save a life, but then obviously if we save a life and you've lost the use of your arms or you've got amputations, that's not great either. So we try to preserve as much of living tissue as possible. The longer we allow that swelling to sit tight and compress structures, we're not going to save it. So that's why the fasciotomy in electrical injuries is the big cut that happens through the damaged muscle to open up the pressure, to release the pressure, to allow the blood to flow, and obviously to assess whether any damaged muscle needs to be cut away.
God, that's going to suck. Okay, take me to skin grafts.
Skin grafts are something that we do to try and reconstruct the large area of the body that's been damaged and it won't heal by itself. So those deep dermal, full thickness burns that we talked about earlier, they just won't heal by themselves. They have no blood supply of their own. The skin tissues like a dead crust that is actually causing badness to course through a patient's bloodstream. So you need to remove it. You remove it and there's the wound. Where you're going to take, how you're going to make it heal, because it's a big hole, it won't heal by itself either. So it might have really good bleedy wound bed, but it's not going to heal by itself. You need to create a cover in order for it to heal. So in order to get that cover, we have to take skin from uninjured area of your body. Quite often it's the top of the thigh or the side of the thigh, and you shave, it gets shaved very superficially. So you take a layer of the skin off, usually a square or a rectangle of skin that depends where you're reconstructing. If you're reconstructing the back of the hands or faces, that sheet of skin will get put on like a sheet because you want it to look as close to normal skin as possible. But if it's anywhere else, normally it gets meshed. So you take the sheet of skin, it gets meshed, so little holes get put into that skin graft, and then it can get stretched a little bit further. So you could take a much smaller bit, put holes in it and stretch it further. So we're very mindful that we're creating a second wound for the person. Yeah. And for somebody who maybe is very significantly burnt, you know, you potentially don't have any skin to take. So you have to use cadaver skin or skin substitute dressings. I was going to say, do we still use cadaver skin? So synthetic dressings or skin substitute dressings that we would then use in order to replace, you know, put something on to enable them to heal. Open wounds don't like it. I mean, we're not meant to have open wounds. That's why we have skin. And as soon as the skin is gone, your body behaves in a very different way. It becomes wet and oozy. It leaks a lot of liquid out of the wound bed. So if you offer it a cover with a skin graft, it heals much quicker because it's like, oh, I have cover. That's great. I know what I'm doing now. It's less traumatic for the body to have wound cover. It's less painful, and ultimately enables the cells, especially when there's little perforations. So if you imagine that this is a perforation in the skin graft, our bodies tend to heal from edges in. So the skin cells that repair the wound, they'll go from the edges of that tiny little perforation in and fill in the gap that's open. Whereas if you have a big hole, you know, the body's gonna have to work really hard to try and get all the cells from the outside to in. It's gonna take many months. So that's why skin grafts really work. But the skin grafts can't cover bone. They can't cover any synthetic materials. They can't cover metal work. So if you had like a hip replacement, for example, we can't put that on top of that. It doesn't work over tendons either, because tendons don't have blood flow, and skin graft needs that bleedy red wound bed. The skin graft itself doesn't have blood flow. It is literally just a sheet of skin, and it will die without the wound supplying the blood flow into the skin graft. So if we say we've tried to remove the dead, damaged skin, but maybe we've not cut enough, there's still some damage there, we just haven't perceived it. You put the skin graft on top of it, it won't live in that area. The skin graft will just die off and lift off. So you want to make sure that the wound that we're putting the skin graft onto is viable. It has really good blood supply that the skin graft can then attach itself onto, and then within 5 to 7 days it tends to adhere, and then you have new skin cover.
What if we do have a burn right down to tendon or bone then? What is that going to not be left exposed? What's the outcome for the casualty there? Is it going to be amputation or?
No, there's amazing reconstructive options available. So I mentioned things like skin substitutes. So slightly outside of my domain, because obviously I'm a burns nurse, I'm not a surgeon. Yeah. But a flap surgery is one of the things. So I know it's a really random term. So a flap is like a sandwich of different layers of the body. So you would take skin, fat, muscle, tendon, blood vessels, whatever you need to reconstruct in the damaged area. You take it from somewhere else that is not injured and put it, literally you lift that whole sandwich of tissue over and replace it back onto the injured area. Because tendon by itself will just dry out. So if it's a small area of tendon, say over the top of the hand that's exposed, you might leave the body to heal itself shut over the top of that area. That's possible. But if it's a bigger, more exposed area, there's no way that's going to heal. It's going to keep getting infected. The dried out tendon, it will snap or tear and keep causing infections and problems. It won't heal well. So you want to heal as quickly as possible. And for that to happen, you need to clean the area. So in theatre, again, an operating theatre, the surgeons will make sure that the wound that's receiving the flap will be as clean as possible, and then you move that skin, fat, blood vessels, muscle, whatever you're moving across, and you attach the blood vessels in the receiving wound. So you need a vein, you need an artery to make sure that that flap of skin is actually alive and stays alive. And then it's very high maintenance for the nurses at the bedside when the patient comes out of operating theatre, because you're monitoring every half an hour to see, is that skin still alive? Because all you'll be seeing is the skin on top. And if it's pink and it's got good blood supply, we're testing it every half an hour to make sure blood is still flowing. There's no problem. So then it tends to be within a few days. If that flap is good, it's good. That's it. It stays there for life.
I find that absolutely fascinating. There's so many solutions, and I think as this stuff continues to accelerate with stem cells and other elements coming into it, they're likely for full or close to, near as damn it, to full recovery for people experiencing some of these things is looking incredibly positive. I want to be conscious of our time today because I want to be respectful of your time, but I'd be remiss if we didn't speak about, because I know you're ambassador for the Children's Burns Trust. And I know I'll be asking you to repeat some of the context here, but for people operating in the home, and I know we have teachers and other elements that listen to this as well, the Family Oops and Burns First Aid book provided by the Children's Burns Trust. I wonder if you could just give us a little bit of talk about how and why this got put together and sort of some of the content in it, because we'll provide a link for this as well.
So, yes, I am an ambassador for the Children's Burns Trust, which is the only children's charity that supports families and children affected by burn injuries. Part of the remit of the charity is not only to provide financial aid or practical support to the families that have been affected by fire and burns, but also to do massive prevention work nationally to try and raise awareness of how burn injuries happen, that they're mainly preventable injuries, especially the ones in children, and half of the patients that we see in the burn services are children, and a lot of them are children under 5. Like we mentioned already, most of the burn injuries in children are scalds, and they get injured by hot drinks, pans that with the handles turned out where the child reaches up and pours, boiling pan over the top of them. So these are very preventable injuries. Ultimately, kids don't cook. They don't drink hot drinks. They don't cook in the ovens. They don't straighten their hair. And yet that is how children are getting injured. So if we educate the children and the parents together, that sometimes feels like probably the best way to try and offset the burden of injury that can be lifelong for many of these families. So the Family Oops and Burns First Aid book I wrote it actually on the night shift whilst I was working in ICU, quiet 5 minutes, and I thought I'll write a little story about an accident-prone family who go through all of the typical presentations that we have, so how people tend to get burns, but also it educates the family who didn't know about first aid. They go to school and learn what constitutes burns first aid. And we know that knowledge of what to do if a burn injury happens in the general public, we just don't seem to know exactly what to do. We might have heard our grandma tell us this is what you do, or somebody said, or we've heard something. So the presentation of people with burn injuries to the burn service, sometimes they've put on toothpaste on their burn, or they've put on milk or egg or creams, ice, all of the things that could make the burn injury much, much worse. None of it is first aid. So the book actually teaches about the importance of 20 minutes cooling within 3-hour window. It's really essential first aid and can prevent you a trip to the burns unit. So actually, if you know to do this at the time that the injury happens, and 20 minutes with a screaming child is a really long time. It's a lifetime, but it's so important because the consequence of a burn injury will be wound healing, but the end of the wound healing is a scar. And to live with a scar that is tight, it's contracted, it can crack, it doesn't sweat, it obviously visibly, that looks, very different to normal skin. And that's for life, for that child, for any person injured. A scar is an unpleasant thing to have that also reminds you of the injury that occurred. And in case of children, it's often the faces, necks, and chests that are affected, and hands. They explore the world with their mouths and their hands. So everything is like to me and this. So those are areas that are so important, functionally, aesthetically, in life. You don't want to have scarring anywhere near that. So if we can teach parents through reading a bedtime story, and they learn together about, this silly stuff happens, and actually I'll remember not to put my cup anywhere near where my toddler is crawling. Maybe, that will educate and inform the public about how to do first aid, what first aid is, and it's definitely not toothpaste or ice. Hopefully we'll see less in way of children getting burns. That's the ultimate aim, is to do ourselves out of a job. We don't want people getting burned.
Chrissy, I absolutely love that. I feel like we've completely nailed the map of that. And I know, listening back to this, you'll perhaps roll your eyes and go, I can't believe we didn't talk about this, or we didn't talk about that. But we're going to drop some links here. So if people look under this episode, they will see a link to, you've actually had many publications, and we'll try and include as many as we can. So the most recent one we discussed, it's a link to the Children's Burns Trust, .org.uk, and you can go there and order yourself a copy of the book. There's also a great little YouTube that people can see on there. Saving lives is not enough. The work that you did with other first responders around the UK. We're going to put a link to your LinkedIn. Is that the best place for people to contact you if they want a little bit more information, or perhaps they want you to come and speak? I know you do a lot of speaking and training with people around the UK. Is that the best place for people to find you, do you think?
That's perfect. LinkedIn is great.
Perfect. Before we wrap it up, is there any closing thoughts, anything you want to leave in the ears of the listener before we look to wrap it up today?
I think the important thing to say is that the first person, when the burn injury happens, so the first person there is rarely me. It's rarely a specialist in burn care who knows exactly what to do right now, right there. The first person there is often a bystander, or the person who's been injured themselves. And quite often they are not quite sure what to do. The next service that has an opportunity to intervene is that emergency service, is the first responders on scene. It might be your community first responders, it might be the fire service, might be the ambulance service, but ultimately that is the point where professional services start to appear. And the opportunity to intervene is so finite. You have 3-hour window in which first aid is effective. If you don't do it there, if you don't prioritize the areas in our body, faces, hands, genitals, feet, that are really important to us as a long-term quality of life outcome, it doesn't get done by the next service. It doesn't get done in the hospital. And by the time they get to the burns unit, just as a matter of interest, find out where your nearest burns unit is. You'll be surprised how far away it is from where you live. By the time they get to the burns unit, it's too late. The 3-hour window has passed. So know the immense power you have as a first responder on scene to protect on first contact and to challenge that trajectory of outcome for that person. You can completely improve it and make it so much better. But by hesitating or maybe not doing it or being too self-conscious or too worried about intervening, you completely impact. There'll be a consequence. Whether you do something or you don't do something, there'll be a consequence. So know that you make a massive difference. You just have to decide what kind of difference you want to make.
That is a great note to close on. I absolutely love that, Chrissy. She's done this before.
It's not mine, I have to say. It's Jane Goodall. So, that's her quote, but I love to use it because it applies perfectly here.
It does. And I always say there's no such thing as an innocent interaction. Even our interaction today with each other, we can have a positive or negative. We're always putting a weight on one side of the scales or another. And certainly for us on the front line, when people are having the worst day of their life, we've gone with the best of intentions. We just need, content, information, guidance from subject matter experts such as yourself to help us reinforce that what we're doing is the best thing to do, because you don't want to turn around and go, oh, I did it with the best of intentions, but I made it worse. Thank you so much for your time today. I really appreciate it. Spending a couple of hours answering my silly questions. Please send my love to your family and everybody else, and I really look forward to speaking with you in the future.
Thanks so much for having me, Pete.
The Firefighters Podcast was created to recognize, acknowledge, inspire, and hopefully even motivate these incredible individuals who have chosen to be part of the first responder community. Our driving purpose is to create a legacy resource for the current and future generations of firefighters and first responders. We get some incredible feedback from listeners and guests, and as the podcast grows, our desire to create longevity and sustainability means that we are asking for the support of our listeners. If you want to support the podcast, if you want to get discounts to our merchandise, hoodies, clothing, coins, patches, tallies, and also access to all of the incredible documents get shared with us from our podcast guests and sector leaders, then please head over to our Patreon page, and for just £3 a month, you can support the future of the podcast. Please finally hit that follow, subscribe, or rate button on the platform you're listening, and wherever you're in the world, please support your emergency services responders, and thank you for listening.